Good morning, everyone. Thank you so much for joining us on our final day of the Virtual Ohio Prevention Conference featured speaker series. We're happy to have all of you joining us. We're just going to take a couple of minutes and allow everyone to cycle into the room and get connected to audio. But once you are in and connected, we'd love to know who you are and where you're from. If you could drop that information in the chat so we know who all is joining us today, that would be great. As I said, we're just going to give everyone a couple of minutes to get cycled in and get connected so that they don't miss anything. We are really excited to thank our sponsors for the event today. Of course, we want to make sure that we thank the Ohio Department of Mental Health and Addiction Services, who is bringing our virtual Ohio Prevention Conference featured speaker series, as well as our weekly webinar series to all of us at no cost this week. So we're really grateful for their partnership in this project. We also want to thank the Ohio Program for Campus Safety and Mental Health and the Great Lakes PTTC for their sponsorship as well. My colleague Anthony will be dropping links into the chat so that you can learn a little bit more about their programs. Both are incredible resources for training. We encourage you to go to their websites and learn more about the work that they do. It looks like we can go ahead and get started. My name is Cindy Clowner. I'm with The Ohio State University. I'm joined by my colleague Anthony Gonzalez, and we're grateful to have everybody with us today. I want to start by wishing everyone a happy new year. It's the beginning of our new fiscal year 21, and so hopefully we can get off to a great start for this new year. Maybe we can just call this the beginning of a new year, since 2020 has started off, at least from a calendar perspective, a little rockier than probably we all were hoping it would be. So we're excited to have Sheila Savannah from the Prevention Institute with us. She's going to be talking about the role of preventionists in accelerating health equity and communities of well-being, and we're thrilled that she's joining us today. Before we get started, we do have some housekeeping things we would like to discuss. We want you to share in the chat with us, if you haven't done so already, who you are and where you're from, so we know who's joining us today. The chat is a great place to share resources and feedback for all attendees. And the Q&A is where we would like you to send your questions that you would like to direct towards Sheila. She'll be answering those questions at the end of the session, and putting them in the Q&A box ensure that we don't miss them. So the chat can sometimes be moving quickly. We want to make sure that we get all of your questions. We encourage you to use the Q&A box for that. This session is also eligible for up to 1.25 CEUs for social workers, counselors, prevention specialists, and chemical dependency counselors. You must participate in the full 60 minutes of the presentation to receive the hour. And if you stick with us through the end, you'll get an hour and a quarter of continuing ed. There will be a knowledge check question at the end of the session, and you're required to complete that to get your certificate. And those certificates will be emailed within 30 days of the session. And so we'll walk through that knowledge check process together at the end and provide those of you who have struggled with polling an opportunity to respond via chat at the very end of the session. Those of you who may have been with us in previous sessions know that we were so fortunate to have the U.S. Surgeon General provide some remarks specifically for our conference. If you haven't done so yet, we encourage you to visit go.osu.edu/OPCSG so that you can hear the remarks that he provided for our Ohio Prevention Conference audience. And with that, I'm going to turn things over to Valerie Conley-Leach from the Ohio Department of Mental Health and Addiction Services.
Thank you, Cindy, and good morning, everybody. As Cindy said, I'm Valerie Leach from the Ohio Department of Mental Health and Addiction Services, Bureau of Prevention, and I am pleased to be able to introduce a definite friend of Ohio and colleague, Sheila Savannah, who is currently the Managing Director at Prevention Institute, with over 30 years of experience in multi-sector collaboration and community engagement, with a focus on building youth family involvement to address wellness, safety, and equity. Her work helps build continuums for local to national efforts which address the determinants of health. Much of this work is with communities of practice that use multi-sector systems transformation to strengthen natural assets and heal community-level trauma. Based in Houston, Sheila provides leadership on projects that take a public health approach, improving community environments to address problems of mental health, trauma, substance misuse, and violence. Her team launched a planning initiative in California where 5 non-traditional collaboratives are receiving technical assistance to prevent domestic and partner violence. Another project in the greater Houston area is accelerating community change to assure that children, youth, and families of color in 10 selected communities can have better quality of life outcomes. Previously, Sheila was a division manager with the Houston Public Health Department and the Office of Adolescent Health and Injury Prevention. Sheila holds a BJ in journalism from the University of Texas at Austin and a master's degree in psychology from the University of Houston at Clear Lake. So with that, I would like to pass it off to Sheila and enjoy the presentation, everybody.
Good morning, everyone. It's such a pleasure to be here and to really join you. I think it's so important, a gathering. This is kind of Prevention Institute's sweet spot to really be able to talk to so many preventionists, and especially at a time when this is where your skills and your abilities and your programs are so very much needed. We're going to talk today really about how, as a prevention workforce and systems, do we accelerate both health equity and communities of well-being, and really build on some of our experiences across the country, but also hope that this is an opportunity where we can tap into your skills and tap into your wisdom and sharpen it as a combined workforce. I want to tell you a little bit about Prevention Institute in case you don't know. We're over 21 years old as a national nonprofit. We have major offices in Oakland and in LA, a very small office in Houston, and one in DC as well. Our focus is on primary prevention. And that means, how do we prevent illness and injury from occurring in the first place? How do we really think about health as really well-being, as thriving, as all those things that we see as protective factors and assets? Because we know when we put those kinds of protective factors in place, there's so many things that are illnesses and injury that we can prevent. We also really work at the community level. And I want you to really stretch your thinking so that as you think about prevention, it's not at that individual level of just behavior change, but it's really thinking about the community determinants of health that impact the choices, the options, the defaults that we go to when we think about health and well-being and safety. So I'm excited to join you, and I want to also tell you a little bit about myself. My mother's father left from Kentucky as a child, as a family that was held in bondage, and came to the Ohio Valley, particularly to Xenia, Ohio. Um, this is a story of how historic trauma really can be migrated into a story of resilience and resistance. His family stayed in the Xenia area. In fact, I used to visit Xenia almost every summer as a child, where he went from being a first generation child outside of slavery to really beginning to build a business. He was a horse breeder, trainer. He trained some Derby horses, some winners. And there he and his sisters, who are also pictured here, built a family life centered around a community that also was beginning to learn to thrive. The land where I used to visit is now part of Central State and the Wilberforce community. And it's so important for us to really kind of pause and think about how close a history that is. When we really stop and think about what are our contributions to this country, and also how do we really think about trauma as an opportunity to learn and understand each other, and an opportunity to be really trauma informed as we move toward resilience. So I want to thank you for the opportunity to be able to talk to people in Ohio, but also I want you to encourage you to think about and learn more about what is your history and what does that bring to the work that you're doing now. I know I'm walking in their footsteps, and so I bet you're walking in the footsteps of those that came before you as well. Oops. There was a report written by Tony Eiton that really talked about, oops, he was the director of the Alameda Department of Public Health, that really spoke to this whole idea of discriminatory actions and how health inequities are produced. Here he says health inequity is related to both a legacy of overt discriminatory actions on the part of the government, the larger society, as well as to present day practices and policies of public and private institutions that continue to perpetuate a system of diminished opportunities for certain populations. And what this means for preventionists is that we always have to have a keen eye toward who is suffering and how do we make sure that our prevention strategies reach them in a way that is culturally appropriate for that community. So we're going to talk about a little bit about how this historic legacy becomes something that we call community trauma. And I think, there we go. And so we've done a lot of work, Prevention Institute has done a lot of work on community trauma and resilience. And I want us to have a conversation on what does that look like in 2020. As Valerie said, this has been a unprecedented year. And as we think about community trauma and resilience, it's so apparent to us. So together, I'm hoping we can sharpen our eye and think about what are the skills that we're carrying forward to create solutions. So thinking about first the term community. At Prevention Institute, we really think about community in a structured way, especially as we talk with different organizations across the country. We use the Thrive tool. It was originally developed for the Office of Minority Health, and it's tool for health and resilience in vulnerable environments. The language is going to sound very familiar because it's also sometimes called social determinants of health. It's sometimes called health factors or community factors. We really came up with some terms in partnership with community to make sure that that it was an accessible concept and really became a way to engage communities in dialogue around changing their environment and moving toward thriving. So the framework is really a way of thinking upstream, and it's a tool to make sure that your actions are geared to moving upstream. It basically breaks down community into three primary clusters: people, place, and equitable opportunity. In those clusters, there are certain factors. For example, in the people cluster, it's the social networks and trust. How do people interact with each other? Also, how do they act for the common good? And really importantly, especially when we think about prevention, is what are the norms and cultures that silently guide our behaviors, our actions, our choices, our expectations? In the place cluster, sometimes called the built environment, we've really come up with a number of factors, and often as we work with communities, they even add to this list. But what's included here are things like what's sold and how it's promoted. So in addition to what stores are available, that also takes into account, especially as we look at substance misuse, what is marketed in this community and how is it marketed and how is that marketing geared towards certain populations or certain geographic areas, and how does that impact health? We talk about safety, but more importantly, we talk with communities about what is the look and the feel of safety. When you've gone into communities, sometimes you get a real sense of whether you're safe or whether you feel like you're in risk. And this is part of what characterizes community. Housing, an important factor, that both in terms of its availability, its affordability, its quality, all of those things are part of what drives health or lack thereof. We know there's a lot of research about green space, open space, accessibility to parks, whether it's for healthy activities or even just for mental well-being. We know that having access to healthy, safe outdoor spaces is very important, and it contributes to health. Air, water, soil quality are vital. I think Flint, Michigan really pointed out for us that water quality is essential regardless of the other factors. And there's other examples around the country. When we talk about transportation, we usually talk about getting around. So it includes beyond the cars and the transit systems, which are really important, but also how do people in a community move around? How do they get to the places that they need to go? And how do they make choices for active or passive transportation? Really important in the built environment, and we'll have some examples of this, is arts and cultural expression. This is also part of how community expresses who it is. It's so important also as a vehicle to tap into the talents of people in that community. So these are kind of things that are built into what we call the place factors. Really, really important is this third cluster, or the cluster of equitable opportunity. What are the opportunities for education? What are the opportunities for living wages, for local wealth, for local businesses? Are jobs accessible? Are jobs at a wage of living? Is it commensurate to the housing that's there? And there's so many ways that education can be considered, both in terms of early childhood, K through 12, but also how is community supporting us as lifelong learners? So I want you to think about these factors, and we're going to use them again and again as we talk today. As we've gone through communities, often what they do in a planning process is they prioritize what is most important to that community in terms of their factors, because that way, as they begin to identify community changes that are important to them, they can begin where the community is wanting to begin. And so we'll talk a little bit more about community engagement, which is really important as a preventionist. So that second word in community trauma is trauma. And as the Kaiser report on adverse childhood experiences was published, as people began to understand more about all of the things that impacted children, that really impacted their health and their lifespan, as that report and that research really was understood more and was disseminated, there were several communities that we were working with that were saying, yes, children are impacted, but we're all impacted. And how do we take into account not just those kinds of adverse experiences that happen in the home, but also those adverse experiences in the community? So in partnership with Dr. Howard Penderhughes, we wrote a report that's on our website. It's called Adverse Community Experiences and Resilience. and then later also did a companion piece that talked about how different institutions around the country took that framework and applied it in their work. The findings of the report were pretty profound. One, that there was a growing understanding about trauma, particularly its prevalence and its long-term impacts. That trauma is pervasive, it has a significant impact on life development, on health and well-being. That trauma-informed care is becoming a standard, especially in a growing number of places, in schools, in hospitals. It's becoming a standard in terms of just how we think about building coalitions that are really impacting complex problems. But also we found that the predominant approach to dealing with trauma is still screening and treatment, which is consistent with an individual medical model. So as preventionists, we want you to think to include those, but also think beyond them. Trauma also manifests at the community level. And it's not just the aggregate of individuals in a neighborhood who have experienced trauma. It's a growing understanding that trauma serves as a barrier to effective solutions to promote health, safety, and well-being. We know that going into certain communities, sometimes interventions don't fit, sometimes they don't stick. And just understanding community trauma tells us a little bit more, one, about why it's so hard to get interventions to be sustainable, but also what are some of the solutions that we can use to make sure that they're more robust and built into the community culture. We also know that there are manifestations or symptoms of community trauma in those same three clusters: the social cultural, the physical and built environment, and the environment of opportunity or economic environment. So to back up just a little and to remind you that trauma is the impact of experiences or situations that are painful, that often make you feel like it is a life-threatening experience. And community trauma is the impact of chronic adversity across a community. Community resilience is the ability of that community to gain capacity to adapt, recover, and thrive, even in the face of adversity. And so as we think about some of the examples that I raised about my family, that is part of community trauma. So what's driving the harm? I know there's been a lot of information about structural drivers, structural racism. So I want to pause and make sure that you understand that structural drivers are the inequitable distribution of power, money, and resources. And structural drivers create the conditions that harm communities. And there's a number of structural drivers that are often present in communities that we see struggle the most. So here you see, once again, those same clusters: people, place, and equitable opportunity. And it's helpful to kind of think of those structural drivers as impacting all of those environments, really kind of surrounding the circle in a way that sometimes feels invisible, but with a preventionist eye, we can identify them, and then we can start planning to do things differently. And that's when we talk about systems change or systems reform. So some of the symptoms of community trauma, which are the manifestations of the impact of structural violence and or violence across a community, what we see is damaged social networks. We sometimes see a low sense of social and political efficacy. We see deteriorated built environments, and we see intergenerational poverty. But what our framework does is really helps you think of those things as the symptoms. And here they are kind of broken into those different clusters so that you can think about long-term unemployment is really the result of a structural trauma on the employment system. And so you see it there pointing to equitable opportunity. The relocation of businesses and jobs, the limited employment options, divestment. Often as freeways or highways are put in, they circumvent certain cities or towns or communities, and then we see those communities, towns, and the people that live there begin to languish. In the built environment, when there aren't investments in lights, in our core infrastructure of water and drainage, we often see deteriorated and unhealthy or dangerous public spaces and a crumbling built environment. We also see built unhealthy products that are marketed to different communities more heavily than others. In the social or social cultural environment, we see disconnected or damaged social relationships. We see the elevation of destructive norms, including substance misuse, including violence, and a sense of collective or political, a lack of a sense of political or social efficacy. Sometimes it's described as the community feels a loss of hopefulness. One community member that we have worked with said, trauma gets in the way of doing what we need to do, especially when it's chronic and not episodic. It's really damaging. So even though we've talked about trauma, I want you to understand also that trauma always exists side by side with resilience. And so communities do have the capacity to adapt, to recover, to thrive, even in the face of adversity. And those are also rooted in the community factors, such as social networks and trust, the willingness to act for common good, living wages and local assets that need to be built upon. And when there's healthy, equitable community design and infrastructure and healthy products that are introduced over a long period of time, we can see communities and people start to turn their health toward thriving. So this is where I want you to really key in on your skills as a preventionist. We're going to look at some pictures and really see if we can pull out, what do community trauma and resilience look like? And the pictures I'm going to show you, I want to really have you stretch your eye to find the things that you say look like trauma, but also the evidence of resilience. And so the team is going to help me. We're going to use the chat function. And as I show these pictures, you're going to identify protective factors as well as risk factors in the pictures, kind of clustered the way that we were just talking about: people, place, and equitable opportunity. So what's community trauma and resilience look like here? And Anthony, I'm going to ask you to help me pull out some of the answers. The flooding is a trauma. Service support. Yeah.
We're seeing a lot of trauma equals flooding, risk in flooding, possible lack of resources to relocate safely, flooding, first responders support.
Yep.
Community, the community heroes come to support. Flooding is trauma. Environmental trauma, supporting caring adults.
Yeah, yeah. And also, you see that they're smiling. You know, that's something that I want you to also tap into, is that when people are helping each other, there's a sense of community pride and kind of a joy that really helps to offset the trauma that people are experiencing. Here's another one. What's community trauma and resilience look like here? Poverty, trauma and poverty. Yeah, broken down housing. Pull out some strengths. Let's see. United housing. Oops. Let's see. I want to go back while we talk about that one. Yep. So the grill. Yes. Yes. People are eating. It looks like a makeshift ramp, but people are trying to adapt. There's space on the front porches. So that could be a strength that could lead to social networks. When houses are this close together, usually the neighbors know each other. The entire picture is resilience. Know your neighbor. Excellent. See, that's why I like talking to preventionists. Let's look here. What's community trauma and resilience look like? Marketing to community. Negative advertising. Yes. Children sitting outside the grocery store. Yeah. Marketing cigarettes. Yeah. What happens when your groceries are, your primary grocery store is really a corner store that doesn't have a lot of produce? Homelessness, that's possible. Food deserts. But also notice that some of the things that you're naming are things that through policy and practice change, through community organizing and advocacy, we can change those things. We can add grocery stores or other food options. We can make sure that some of these things are addressed. Great. Oh, you all are strong and amazing. Kids have a backpack, after school programs. Good eye, good eye. Tell me about this one. What's community trauma and resilience look like here? Natural disasters, yeah, destruction of property, tornado, homelessness, relocation. Yeah, lack of insurance resources. Yeah, pull out some strengths. What happens in fear? Yeah. What happens in communities that are often hit by disaster? They bond, people come together, they drop their differences and learn to really support one another. Yeah. I have another one for you. Whoops, there we go. So what's ooh, I went too many. There we go. What do community trauma and resilience look like here? Disease. Yeah, these pictures are from this year. Our frontline healthcare. Yeah, teamwork, working together, risk. People put in their lives on the line really to make sure that others have health. Yeah, not enough. Selflessness, important point. Yeah, so now you see how all of those things that we pointed out as community factors are all interacting in these pictures. Here's another one. What's community trauma and resilience got to do with this? Activism, yeah. Voices, advocacy, resilience, oppression, yeah. Systems that are broken, a lack of feeling like a change can happen, standing for unity. Also young voices, young leaders. I see a couple of people put that in the chat, Anthony. Yeah, yeah. reliving the trauma each time a community member is killed. So these things of community trauma and resilience, they occur side by side in an intertwined way. And as preventionists, it's important for your work to hold that balance and make sure that we aren't sugarcoating the issues, but we also aren't dwelling on them so singularly that people can't find a pathway toward something better. People are unbelievably resilient, but also something to keep in mind is that traumatized people interacting with other traumatized people, a community can really run the risk of imploding. And so I want us to think a little bit about how do we encourage healing and accelerate equity, especially when we know that the structural drivers are pervasive, they are baked into systems, they're structural. So part of our adverse community experiences and resilience framework also talks about strategies to address community trauma. So what you see here in the middle is still people, place, and equitable opportunity. And we know there are lots of factors in there. And along that outside edge, we see those systems that hold the structural drivers in place. If you see this as possibilities for systems that could be part of collaboration, you can see how they have a choice to reinforce equity and healing or risk and deterioration of certain communities. And so when people are really brought together in a way that sparks opportunity for change, we've seen like a healing that begins to happen. But that means that also those systems have to acknowledge the harm that they're doing. They have to pause and think about their policies and practices and whether they're overtly or inadvertently causing harm. They have to really be willing to change and willing to partner differently with community members, with community organizations, and create that environment that allows for healing to occur. Some of the factors that we see that are really important for this work to occur is there has to be belonging and connection. We have to invite those that are most impacted by the trauma to the table and create an environment of belonging and connection. And I really want to re-speak what I said, because often it's not inviting them to our table, it's us asking permission to go to existing tables in communities where people are struggling and trying to really build solutions. Our collaboratives and our communities have to be conscious of safety. Is this a safe place for me to voice how I'm feeling and how I feel that systems have treated me? Is it a place where we can build trust, where we can have challenging conversations and maybe get all in our emotions and feel like we need to walk away, but also trust that people will come back because we have a sense of common dignity? We want the higher solution. So when those things like belonging and connection, where safety, where trust, where dignity is exchanged, that's when we begin to see hope and aspiration emerge, where community members begin to envision a better community. That's also where they're able to be part of developing plans that demonstrate control of destiny and self-determination. I want to give you some examples. We talked a little bit earlier about the importance of cultural arts. Public art is a way of creatively voicing collective emotion. And when it's celebrated, it serves as a reminder that this community is healing. Another example, we talked about community-driven planning. This picture is from San Diego, where young people came forward and really began to identify their priorities. and co-led solutions. And what's important about that is if you look real closely at the picture, what they said were important was they wanted to have a community with living wages, healthy housing, good education, and a look and feel of safety. They pulled their priorities out and began to develop a hub where they could gather. They could hang out as teenagers, but also they could think about how do they serve their community to begin to, one, learn how to prepare for interviews, work on homework, think about housing, learn more about the community, and begin to accelerate those changes that also created an opportunity for them to be seen as leaders in their community. Responsive planning and pivots. This is really important because when we listen to community and what's important, and this is from Resilience Grows here in Canton, Connecticut. This was a project focused on veterans, and whereas the original plan was around clinical services and peer support groups, the vets kept saying, and active military folks kept saying, we like this dog idea. And even though that wasn't part of the original plan, once the team was responsive to that, it really became an attracting point. So really being willing to pivot plans to what the community is saying is so important to building an environment of healing. Investing in the natural community practices. As preventionists, we need to make sure that we're not building in interventions that are displacing the healing opportunities that are already occurring in community. So this is where we have to really, instead of we will build it and they will come, kind of looking at what's already being built because they're already there. So really identifying what are the talents, the natural resources in a community. How do we begin to build on restorative justices and invest in those things that the community has already said are important? Often that is really building capacity to help others and self. On our work with boys and men of color, as well as veterans, often people don't want to seek help. And I think this is also really evident in recovery programs. They'll come to help each other, but in doing so, they're also helping themselves and connecting better and closer in a way that has them closer to a hub of support when needed. Placemaking. One of the things, and I think we talked about in the pillars of well-being, the importance of belonging and connection, having informal places in communities that are gathering points that are also safe and constructive. And so this is in Kalihi Valley, Honolulu, it's a bike shop. So the high schoolers come in, they work on bikes, but they also work on life skills. They support each other in healing circles where they talk about how it feels to be in one of the last remaining working class neighborhoods in Honolulu. And really, they've done a lot in terms of civic advocacy, in terms of bike lanes and transportation equity. When we talk about equity and we talked about green space, this work is often about advocacy and multi-generational connections. So here you see a number of the mothers and grandmothers in Los Angeles that are working on park equity. And through this work, we are able to see that change and investments can happen. But there has to be a platform for people to demand it. And so our work, even though it may be in one area, as preventionists, we should also start thinking about what are the ways to sustain this through policy. So to expect resilience without justice is simply to indifferently accept the status quo. So what I hope you saw in each of these examples was the process of engagement and listening, but also the process of providing support and advocating for larger community change. And I'm going to pause real quickly. Anthony, do we have any questions in the chat before we go on?
I don't see any questions that we've missed come in through the chat, Sheila.
Perfect, perfect. But also let us know if you do have some. And someone did ask, can we have the presentation? Yes, I think it's being recorded, and so through Ohio Moss, this will be available. So what can be done to prevent and address community trauma? We've had some examples that gave you a broad brushstroke that lets you know it is possible. It's not easy work, but it is possible. And really, let's hone in on how do we think about substance use? Whoop. So in partnership with ASTHO, we wrote a book chapter that really was looking at a public health approach to ending the opioid epidemic. And part of that chapter, we really posed the question, what are we preventing? And so when we talk about downstream prevention, you know, it's prevention, but we have to ask ourselves, what are we preventing? So are we preventing opioid use deaths? Are we preventing prolonged misuse? Are we preventing exposure? And so the further to the left we move over here, we're beginning to talk about primary prevention. And so as preventionists, I want you to ask yourselves the question, in your work, what are you seeking to prevent? And how could you move further upstream? If we think about the current environment and the continuum of COVID-19 responses, we can look at that same primary, secondary, and tertiary response. If we focus on preventing COVID-19 related deaths, we think about heroic measures in hospitals. But if we think about preventing overwhelm of our hospital systems, then we're talking about how do we make sure that people can recover at home and have reduced symptoms. If we think about really how do we reduce inadvertent spread, that's where our solutions are leading toward contact tracing. Tongue twister there. And really that intervention is reducing the spread, but moving further upstream, when we're asking people that if you're exposed, quarantine, self-quarantine, then we're really talking about preventing the spread. Further upstream, even yet, there are opportunities for us to reduce community exposure, especially of those most affected. That's where we've seen things like grocery store hours that have tailored to seniors, or better yet, home delivery of meals. That's also where we've seen the reminders in every place to wash your hands and cover your face, and make sure that if you're feeling any kind of symptoms or have had exposure, that you're conscious of not putting others at risk. And then here, where we're assuring and maintaining health and safety, how do we begin to look at what are the risks that cause people in some jobs to be able to work from home and others to need to be in the public space? And how do we make sure that we're thinking about maintaining health and safety? That's also where we think about equity the most. For example, many schools went to online learning, and how many kids were left out of that opportunity because of availability of Wi-Fi, or the affordability, or the presence of devices that they could use for their ongoing learning. So as we move toward primary prevention, we're beginning to think more at the population level. And how do we create solutions that really protect the entire community? Whereas those that are more at the tertiary level are what we consider one at a time. I want to talk a little bit about our work in Ohio, where really we use the Thrive framework, and we used our adverse community experiences and resilience work as a launching pad to really think about the community trauma informed approach uh, in, in, um, in really creating solutions for the opioid epidemic in Ohio. And it was in partnership with Ohio Moss and Ohio State University, and really worked with 12 communities or counties, I'm sorry, across the state that were most impacted by the opioid crisis to create plans that really led to more resilient communities. So they were to develop a community level prevention plan that really considered the community environment and tried to dig in through their data to think about what were the community conditions, what were the norms that were contributing to opioid use disorders. Um, Part of that conversation is, as you back up and look at root causes, also those collaboratives were able to start thinking about how those community factors really were driving other impacts, other issues such as mental health, chronic disease, and that these were very complex and multifaceted issues and therefore called for multi-sector partnerships. Some of the factors that the communities identified were things like loss of industry, high rates of unemployment, broken relationships, and lacks of social supports, social isolation, and then that pervasive sense of hopelessness. So I hope you're beginning to see a pattern that these are some of the same things that we said were symptoms of community trauma. What was done there through Ohio Moss was really to look at things like the Thrive tool as an assessment tool in multiple ways. What factors in the community environment were driving the opioid epidemic? But then also, how do we use that as an inventory of what partners should be at the table? Who should be part of the solution building? And then also the strategy development, where what are the highest priority Thrive factors for your community, where there's a collective drive to begin to work together. Some of the strategies that emerged were to promote social connectedness, to increase economic stability and reduce social isolation by increasing access to transportation and increasing safe, affordable housing options. So I hope you can see that even though these kinds of solutions were geared toward the opioid epidemic, they are also solutions that can benefit and address other chronic conditions. We know that these were wicked problems, and so our strategies that emerged, those collaboratives had to be really creative and think about how could they come up with strong multi-sector partnerships and solutions. Also, that opioid use and misuse is complex and ever changing. So it's intertwined with other problems, and no one organization or sector ever has a single answer. So it really began to build an ecosystem approach to engage new multi-sector partners and take an integrated or comprehensive plan to address those issues in a systematic way. One example that we use is from Ashtabula, Ohio. And starting always with strong data, ALICE, which is Asset Limited Income Constrained Employed Data, really helped that collaborative understand that while one set of data said that 20% of their households were living below the poverty line, but when they thought about living wages, they thought about the cost of living in the areas, they really found that it was closer to 31% of the households that were struggling to meet basic needs. And so their intervention began to really focus on how could they help provide some supports for getting ahead, and really took into consideration that they weren't talking about 20% of the population, but really a lot of people that were employed that still could not make basic needs. So that's a taking an equity approach where you look at the data, but did you also look at what are the factors behind that data that may mean that you need to cast your net wider or deeper or more specifically so that you are really addressing some of the root causes and those that are struggling the most. One of the quotes from that work that I love is that working on community determinants is both scary and reassuring. If we don't do prevention at this level, we'll always be chasing the problem. Anthony, I want to pause again and see if there are any questions or comments in the chat that we want to call out.
One came in a little bit ago. How did you get compensation for community members to be equitably involved in the work?
Excellent, excellent. You know, one thing that we often say to our collaboratives is your budget is a value statement. And so we've worked with a number of funders, and we encourage you to really emphasize with your funders that it's important to be able to stipend or pay community members as they are part of the planning and advocacy process. And we've seen it happen in a number of ways. Sometimes it's stipends, sometimes it is developing jobs that are part of your change process or your initiative. In the work in Houston, we see a number of what are called community researchers. So as they're doing their community assessment, they're paying people in the community to go door to door, do some of the interviews, do the surveys, and also to sit and look at the data and bring context to it. That is really important. Another strategy that we feel really strongly about is tapping into community health workers and those systems, and how do we make sure at a large system level that those kinds of positions are paid, that they're not seasonal, but they also are done so that there's a living wage for whether they're called promotores or community health workers or community organizers, or in violence prevention, they're sometimes called interrupters. Those are really valuable positions because they're often trusted members of the community that can help you accelerate, organize, and mobilize the community, and importantly, help initiatives build a sense of trust. So good question. Thank you. I wanted to point out some of the skills that I hope that you've picked up on. You know, really learning from both quantitative and narrative data. There's an example that I love from Houston, and there's a community that I used to work in Third Ward, and there was this area that was determined to be the neighborhood or the area that was probably the least safe, because when you looked at the police data, there were so many police reports. And it was just this abundance of police reports. So when you looked at the geocoded maps, they popped out as red. But when community members looked at that, they were able to add the context that this was a neighborhood or a couple of blocks where many of the people had lived there a long time, and they knew each other. And one of their norms was, if we see something unusual, we're all going to report it, because often the police didn't respond as requested in that area. And so the data showed all of these reports that was interpreted as a risk, where actually for the people living there, it was speaking to the fact that they were all vigilant, alert, and aware of what the norms were for their community. So it was really a protective factor. So that's why it's really important to look at the data, but also visit with the community that is the subject of your work, so that you're getting that rich context that's often missed when we just look at aggregate numbers. Importantly, approach the work with cultural humility and see strengths. You all used a lot of really good examples. So as we looked at those pictures, see risk, but also be mindful that people live there every day. And sometimes they too forget to see the strengths. And so it's really important for us to keep our work balanced, because in order to have a base to build on, we have to be able to find those assets that begin to be sustained and strengthened. Share leadership and work alongside community members and other partners. Unfortunately, sometimes in the nonprofit community, things are set up so that it's a competitive nature. I think we have to find ways to move beyond that, so that community organizations find ways to really work together, and that together they work in partnership with community members who have a lot of assets, who also have a lot of knowledge. We talked about investing in community and culturally rooted practices, and making sure that our interventions aren't displacing something that was naturally occurring. Community members that are there 24/7, small organizations, small nonprofits. I think someone pointed out in the picture with the corner store, the store owners really think about, where are the community assets and those connections that can be the base for building stronger communities. And let's make sure we're not displacing them, keeping that deep tap root in community. We have to understand and acknowledge community trauma. We've got to really work on issues of racial justice, economic justice, gender justice, really find new language and new courage to have those conversations, and really pause and just acknowledge and understand each other at a deeper level. Once we do that, it begins to pave the way for us to work together differently. In our systems, in our organizations, in our policies, there are implicit biases across race, across gender, across socioeconomics, and other isms. And so it's almost taking an investigative approach to see, where are these things written into policies and practices? And then also, how are they applied? We know that in schools, the same type of action across number of children, there's disproportionate punishment of children of color for the same infraction. We know that our justice systems pattern themselves similarly. We need to, in substance misuse treatment, look at, where are we placing treatment services? How are we really building in equity so that they're available at the levels needed for those who are most in need? So that means that we have to look at our data, and we also have to look beyond our data. One thing to remember is that changing community factors should be driven to change health outcomes. So keeping our eye on, what are the endpoints that we want to accomplish, and knowing that if we're acting one at a time, we're going to have aggregate strength. But if we're working on changing community factors, we can have more population impact. It's a little hard to measure, but it is worth it, because then we can reach more people and we begin to permeate those norms that invisibly hold those structural drivers in place. The further we work upstream, we can impact more people. And you saw that with those arrows. And then be introspective and willing to change. A lot of this work is about pausing and putting ourselves in check, or having those accountability partners that can say, no. And so I think those kinds of trusted partners and trusted relationships allow us to each grow as preventionists and be part of an ongoing learning workforce. I'm gonna pause here, and Anthony, if you kind of give me a time check, how are we doing on time?
I believe we have about 15 minutes for questions.
Okay, so I am going to really quickly, I hope most of you already know this story. If not, then I want you to think about, it's like a stream. And I think you can research, just look up public health story about moving upstream. It's a story that's an analogy about people in the river. It's a little gruesome, but when you think about it, it's really more about how do we begin to move upstream. One, to find out, why are people in the river? Are there holes in the bridge? Are there slippery slopes that they're sliding down? One of our partners also reminded us that also beyond that, how do we go to where the stream is really pure, where we're really talking about building on strengths and assets? And I am going to pause here and, whoops, I'm gonna go back one just so it's not quite as distracting. But just to say that when you start with needs only, we'll get programs. But when you start with strengths as well, you get possibilities. So I think we will open up, is it through the chat, to look at questions?
Thank you, Sheila. Now is the time for questions. We'd actually like your questions in the Q&A box, just so we don't miss them. There's quite a bit in the chat, and
Okay.
we're fearful that we may overlook a question or two if they go in the chat box. So if you could send your questions through the Q&A, that would be preferred. We also have a knowledge check question that we're going to activate now.
Right.
And so if you need continuing education, we ask that you respond to the knowledge check question that is hopefully on your screen. And we'll keep this up so that you have some time to review it and respond. There's actually two questions here. So Sheila's asking you to take it one step further and also think about a skill that you need to work on. So we have some action steps as we leave today, which I think is really great. While we're waiting for questions to come in, and we do have quite a few, I just have a couple of quick housekeeping things. We have our final presenter for our featured speaker series that's happening this afternoon at 1 o'clock. It's Tony Coder with the Ohio Suicide Prevention Foundation. There's still time to register for that session, so we encourage you to visit the website on our screen. We also have a webinar as part of our weekly webinar series that's happening tomorrow at 11 a.m. It's featuring Karen Vedino, Resiliency, the Art of Living Well, and there's still time to register for that as well. You can use the link that you find on our screen. I'm going to go ahead and pass it back to Anthony. He'll get us started with questions.
So we did have a question come in that I missed, so I just wanted to get to that one first. Can you give suggestions to develop innovative funding strategies to support natural prevention that takes place in the community? Many times quality program proposals are rejected for funding because they are not evidence-based.
Correct. You know, and that is something we've worked with a lot in terms of funders. I think it's important that universities partner differently with communities, because as you have students that are needing to do research, so often they're creating research that is reliant on data from the community, but not in partnership with the community. So that's an opportunity to really support community efforts by creating that beginning of an evidence base and really changing the evidence base. So as university departments or professors or students are keyed into what is my community doing to create solutions around this, and then building that evaluation that supports you as a student. It supports the university in having cutting edge research, but it also supports the community in having a stronger third party evaluation that, that they can use for funding. Also, as we think about those systems that often come to the table for for collaboratives, to ask them what are the barriers to contracting with small community organizations. Sometimes it's the insurance criteria, sometimes it's just patterns of funding who we always fund. So, you know, how do we also have conversations of looking up the funding streams and creating opportunities all the way along?
Great. Sheila, can you share a little bit about how the strategic prevention framework and Thrive intersect? It seems like Thrive might be more suited to complexities and community involvement, which we know is so important.
Sure, sure. And I think our work with Ohio Moss really showed how those two intertwine. I think it's important for collaborative members to know both. And so when they know both, they can think about both the strategic framework and the SPIF and how Thrive is really looking more granularly at community factors. And so kind of grouping that data by factors, grouping those partners by factors, but then using the SPIF as a way to organize your collaboratives and your strategic planning process.
Sheila, how do you evaluate progress on an annual basis?
That's pretty unique by communities. I think one thing that we're seeing is that when community partners can use their data as part of a collaborative. So starting with, if you have a number of partners, and let's just say parks and libraries as well as health at the table, find out what data do they need for their leadership? What data do they collect? And once you see what's already in your collective system to collect, you're able to go back to your vision, your goals, and say, well, what are the indicators that tell us that we're getting closer to our goal? And often, if you build it into existing and required data collection methods, then you're able to keep that partner at the table because it becomes a win-win. It becomes something that they can say, we not only achieved the number of visits to the park and the kinds of healthy activities, but we also made sure that it was tied to our long-term recovery partners. And we opened up the parks and awareness of that to a new audience. So it's really, once again, building on assets, and partners are assets, and then interweaving the kind of data that you collect. There's also a number of measures that I can send to you, to the team at Ohio Moss afterwards, just in terms of some of the new research that's coming out just around social connection and community change. So it's pretty exciting. It's a little bit pushing that base of evidence. And I think that that is part of what will help us show that community change is possible and that it has tremendous impact across a number of chronic conditions.
Great. I know in the chat we've got a few people who are struggling with the poll question because it's a little bit longer in the past. So we still have questions that we're going to pose to Sheila, but I'm going to skip ahead a little bit. For folks who are having a hard time responding to the poll question, this is the poll question that counts towards the knowledge check, and you can provide your answer to us via chat. If you submitted your poll, you do not need to do this. So this is only for folks who are struggling with the poll question. So Sheila, how do you avoid further trauma by utilizing community members within the work, as in some peers in the field feel like they can never shut off since they're living and working in the same
Right.
communities?
Right. You know, we hold that balance in the collaboratives that we work with across the country. When I say we hold it, we're ongoingly conscious of it. And I think for collaboratives, it's something that's both unique, meaning that every collaborative needs to build its support system for its members. And so one way is to make sure that there is enough community members at the table, so you're not relying on one person that gets burned out or a handful of people that get burned out, that it's really something that allows a community voice to emerge. And then also that they have a safety net. They have partners that are aware of things that trigger trauma for them, and that they have a way to be able to back up from the work and come back into it in the ways that feel healthy and safe for them. But great question.
Thank you, Sheila. So what are some ways you suggest overcoming organizations or persons who feel they need to save communities or refuse to include communities as if they do not know what is good for them?
Yeah, you know, that's a super risk. I would say early in my career, I told people to start working in their own community first, because we know that trauma and assets occur in every community. And so it's really important for people to first do their work in their community or also alongside, especially when you look at something like substance misuse. It's across all socioeconomic levels, all geographic levels, and working in your own space, it does a couple of things. It really helps you understand both sides of the traumatized community as well as the assets that reside there. And that makes you so much better when you are able to work with other communities and not try to do two communities, but really it's more about creating an opportunity for communities to do for themselves. And that's one that it takes practice. It takes work. It takes accountability partners that can say, that seems like the balance is off.
Thanks, Sheila. We're technically at our time, but we have a lot of questions still. So I'm curious, Sheila, are you able to stick around with us for a few more minutes? Is that okay?
Yes, I
Oh,
am.
we appreciate that because these are some really great questions. So
I
thank you.
see. I
Uh,
see.
So do you have suggestions for the best quantitative indicators for measuring community adverse experiences, or community resiliency, or ways to assess improvements regarding population level improvements, as you mentioned, particularly in context of trying to prevent substance use disorders?
Wow, good thing. Really good complex. That could be a whole talk. Um, I think when we've looked at impacts of community trauma and resilience, we go back to those symptoms because they are going to be proximal indicators. So beginning by measuring those on the quantitative side and then qualitatively being able to have context seems to be the best way for communities to discover what would be the metrics or indicators that they could collect at that local level. So for example, when we think about livable wage, you know, and so that's a big umbrella. And so being able to then look at the employment patterns in that particular geographic area or among that population, what kind of jobs, what kind of earning potential is there, and it allows you to look at education, that whole system that leads to livable wages. And then going back to your collaborative partners and seeing what is the data that's collected and what are the nuances behind that. And so it's more, instead of giving distinct indicators, it's to me more of a process of arriving at the indicators for a particular collaborative or project. So I hope that was helpful. I can also send some articles on the hope measures, some things that are really beginning to look at that. But it is a new wave, I would say, in terms of the evidence base.
Thank you, Sheila. And so I don't think this question will be as complex. How do we connect communities with the Prevention Institute?
Go to our website. We have links. Please sign up for our e-alerts, but also there is a link there where you can ask a question or you can email us, and I can really engage others in our team to really be able to answer your questions as well. There's also lots of really cool reports and videos. Our e-alerts also link to our social media. And so we also look forward to connecting you in different ways.
Thanks, Sheila. Do you have suggestions to encourage those in charge of coalitions or committees to help bring more diversity to the table and help those that are coming feel comfortable, heard, and valued?
Sure. We're always in conversations with communities about how do you make that work. And one of the strategies that I've seen is one, not abandoning your table, but putting that on pause and going to other tables to just listen. Because by doing that, you can find out what are the goals of other organizations or leaders and really it's almost like doing a listening tour so that you really are understanding the same issue through someone else's eyes. And also being able to see what are the things that are being worked on as solutions. So that way, when you form a collective table, and I deliberately say that it's not about inviting somebody to your table, because when you say it's your table, it's already has some ownership there. So building a collective table is really saying, well, what are your goals, your objectives, your interests, your vision, and how does that match up with the vision of our organization? Um, what happens sometimes is for existing collaboratives, some partners don't get patient with it. And so I don't want to say that it's easy work, but it's good work. And it's the work that needs to be done if we're really going to engage people in an equitable way. But that's a great question.
Sheila, what do you think are the best way to evaluate our progress annually as a coalition?
There's a couple of measures that I really like. There's one there's some of them are just process measures. Are your members coming? Are they coming and actually working? Are they doing things in between? Are they sharing leadership in the overall goal? So those are some kind of process measures that you can look at your internal practices. Also, there are things like the scale of engagement, and I'm drawing a blank on who, but Hearts is one of them. Hearts ladder of engagement is in youth development, but there are several others that look at, are people just there and informed, or are they truly are we communicating that this work cannot happen without you? Or are we communicating that this is really shared work that empowers everyone at the table? And so I think that especially if you're engaging parents or community residents, to use processes like social network analysis to be able to measure on an annual basis, are people really feeling like they're part of a network, or is it still just a single point of coordination? And so you want to be able to take those measures often enough so that you're able to see where are your challenges and how do we deliberately work toward building a shared network of leadership.
Sheila, this is another long and a bit complex question, so bear with me. But we'd like to know more about how communities can move upstream when they're not supported by the government. And this attendee provided some examples around, our preventionists know what they want to offer, but oftentimes our community members are in a survival state, and use the example of food deserts that you showed to illustrate that. So if families are not sure where their next meal is coming from, then how can there be a solution? And when communities are not receiving the support for several generations, then how can they trust that our work will make a difference?
Yeah, yeah. I think that's where it comes down to starting where people's priorities are. So the question would be, how can the collaborative address the issue of the food desert? How can you, one, be conscious of gatherings of food, but also, whether there's farmers markets, whether there are plans to begin to address the things that they feel are priority. And so I think that's a really important piece. And sometimes we don't see that as part of substance misuse prevention, but I think it is, because when people are in places of trauma and pain, when they really are needing to and not finding ways to cope from day to day or feeling hopeless, I think that that's often where we see elevated levels of substance use. Some of the other things is looking at outlets of alcohol or drugs, pop-up pain clinics, the whole works, and beginning to work toward those while increasing access to healthy food options.
Thank you, Sheila. And I think we just have one more question left. How can we create data and such to continue progress and convince stakeholders?
Yep, good question. I I'd say start with, what do the stakeholders need to know? What I've found in a number of coalitions I've worked with is often the stakeholders at the table are accountable to other stakeholders in order for them to be there. So really getting those conversations on the top of the table to say, what do you need to show progress with in order for this work to continue and grow? When stakeholders then, as agencies, organizations, and community members are able to see progress in what matters to them, then they're able to go with a collective, stronger voice to stakeholders such as policymakers and legislators. So I think it's really getting to know your partners, including the community.
All right, Sheila. Well, that is all of our questions. We appreciate you so much for sticking around with us a little bit over your time so that you can answer all of these questions, because they were great. This session was really phenomenal and valuable to our community of professionals in Ohio, and we're really grateful that you were willing to present for us today.
I appreciate the opportunity.
Absolutely. We do just want to remind everyone about all the great collective impact efforts that are happening here in Ohio, and encourage you to reach out to and find out more about what's happening in your community by visiting the Collective Impact website. We'll drop that here in the chat so that you can take a look there and learn more about what's happening here in our own backyard in the state of Ohio. I think we have hopefully everyone has had the opportunity to complete the knowledge check question. It's on our screen. You can send your response via the chat to us as panelists. We'll be putting the recording and a PDF handout of the slides on our website here next week. It'll probably take us just a little bit longer because of the holiday weekend, but be sure to check back next week so that you can take a look at the slides. I know that was something that lots of people were really interested in. So thanks everyone, and we hope to see you all this afternoon.
Thank you.